núna held ég að þetta sé byrjað sko. Því að nú sé ég mynd allan að sjálf mér hérna á skjánum. Þá held ég að streymi sé að byrja að rúla af stað. Verið hjartanlega velkomin á þennan hádegisfyrirlestur hjá Þjóðminjasafninu í dag. Og gestur okkar ekki af verri taginu. Það Dr. Cecilia Collins. Hún mannabeina og fornmeinafræðingur. Og hún hefur komið víða við á sínum ferli. Meðal annars stundað sínar rannsóknir hér á Íslandi. Kom hingað 2008 og var þá að nema við Háskóla Íslands. En hún lauk svo síðan doktorsgráðu sinni frá háskólanum í Reading á Englandi 2019. Eins og ég nefndi áðan þá hefur hún komið víða við og starfað af mjög miklu og á mörgum stöðum, meðal annars í Bandaríkjunum og Bretlandi og Sviss og Hong Kong. Núna hins vegar þá býr hún á Íslandi, býr hérna í Reykjavík og starfar í háskólanum í Reykjavík. Og Fyrirlesturinn á ensku, gott fólk, og tekur ákveðinn tíma og í lokin þá gefst tækifæri fyrir spurningar. Og mér sýnist að það þetta dálítið síðan að ég hitti Ceciliu, en hún bara ansi fær í íslensku. Þannig að hugsanlega bara allt í lagi að spyrja á íslensku en þið megi alveg líka spreyta ykkur á enskunni. En ég ætla ekki að hafa þetta mikið lengra að svo stöddu og biðja Ceciliu að kynna sem fyrirlestur. Gjörðu svo vel, Cecilia.
So thank you for that. Thank you very much for the invitation to come today. I appreciate the privilege of actually being able to come back to be in Iceland, and this is the first time I suppose that I've publicly presented the results of all of this research here in Iceland. So I'd like to just advise anyone watching that there will be photos of human remains in this presentation, and also in the interest of accessibility, I'm happy to provide a transcript to anyone who requests it. So my presentation today stems from work done during my Ph.D. and draws on current research paradigms in archaeology and paleopathology, specifically the study of disability in the past, the bioarchaeology of care, and the archaeology of childhood. My thesis examined evidence of infectious disease, especially tuberculosis, and the prevalence of sinusitis and otitis media. So recording prevalence rates of pathological change, observing what's normal and what isn't normal in the sinuses and ears, and comparing different cohorts by age and at different sites, what does gathering this kind of evidence do for us? Essentially, this can better inform the narratives we shape about many aspects of life in the past and help us to understand the lived experience of the people in those communities that we try to depict in archaeological research. So some definitions. In bioarchaeology, individuals are regarded as keepers of biological and social data, accessible primarily perhaps through the skeleton. It enables us to explore community dynamics and contribute to methodologies for studying different cohorts. The bioarchaeology of care, in particular, is a model which relies on clinical literature to understand physical impairments and disability in the past. And recently a shift has taken place to apply this model, the index of care, not only to case studies, but more widely to populations. As for disability, you could probably do an entire series of lectures on the conversation about disability in archaeology and how that's progressed, but today I thought perhaps this would suffice to say that disability, as a partial definition, disability as comprising biological, psychological, and social elements, and is being produced through interaction between physical and or cognitive dysfunction and the cultural and physical environment. And regarding the archaeology of childhood, I want to share a quote from Grete Lillehammer, who was one of the pioneers in looking at children in archaeology. "Real explanation about past societies is not possible without including children. The sophistication of archaeological theory and practice steadily increases the knowledge and understanding of cultural and biological aspects of life course, gender, identity, socialization, and acculturation in past societies. However marginal the traces of children's bodies and bricolage may seem compared to adults, archaeological evidences of childhood are spread to the most astonishing spaces and places. It is hidden within and below a variety of surfaces and beyond in the depths of human mind and body of both children and adults. Crucial proof of the interrelationships between children and the environment at macro/micro levels in human society is that the history of the archaeology of childhood is not all about children." Our ongoing experiences with pandemic and endemic disease have to some degree forced us as a society to examine the overlapping and convergent nature of experiences of chronic illness and disability as we currently negotiate living with a new endemic disease in some form or another. We can explore care-related implications for the community, including the presence of syndemic disease. The bioarchaeology of care and disability studies have focused quite heavily on mobility, or evidence for the lack of mobility in case studies especially, and some criticisms have also been raised that the bioarchaeology of care has focused largely on adult individuals and somewhat neglected children. The goal, of course, of all of these models is to better elucidate the lived experience in the past. This research has sharpened our understanding of the prevalence and impact of tuberculosis in Iceland, and more broadly has given us a sizable data set of biological evidence of the effects of TB in its tendency to create more severe sinusitis and otitis media. And that's presented us with the opportunity to identify hearing loss in the past. It also allows us to dispense with theories that impairment of the senses, in this case hearing, will not be detectable in human remains. I want to highlight here some recent interdisciplinary directions taken in disability studies. And here's a very recent new article where Joaf Tiras has looked at the lives of deaf and non-speaking people in late medieval Iceland, and he's demonstrated that they did indeed have means to communicate, formed loving relationships, and participated in public life, as we see it in written sources. At the same time, the archaeology of childhood and studies of disability in bioarchaeology have been crying out for population-level analysis and trying to apply and modify the frameworks we currently have. So as a population-level study of disability, this study allows us to move beyond case studies, though these do have a place in paleopathology, and reveals a hidden disability. So with some brief definitions in hand, I first want to contextualize the home environment, and especially the risks associated with respiratory infection at home. Respiratory infection is a global health concern, and one of its major causes is pollution in the indoor environment, especially the effects of biomass fuels. In the UK, in a 2019 report, wood and coal burning in homes was estimated to cause 38% of outdoor PM2.5 pollution, and that produced by only 8% of the population. It's a really very small proportion of people having a huge impact. The use of biomass fuels has been associated with an increased risk in chronic obstructive pulmonary disease and an especial increased risk of lung cancer in women and acute respiratory infections in children under 5 years of age. Women and children have been recognized as particularly susceptible to these disease risks, as they may be in frequent or even constant proximity to burning fuel and the resulting pollutant and particulate matter. Prolonged exposure to solid and biomass fuels also increases the risk of pulmonary infections, especially tuberculosis. So this chart, I thought, nicely illustrated the huge impact of environmental factors in the development of chronic obstructive pulmonary disease. Tuberculosis, of course, remains a major global health concern, and there is a strong association between having a history of TB and the development of COPD in non-smoking patients. The risk of airflow limitation in patients with a history of TB is more than twice that of patients with no TB history. The chronic inflammatory response and long-term TB-associated structural alterations can include airway remodeling with scar formation. So, turning our scope to Iceland, the hearth of the turf house figured large in the life of the household, providing a central source of light and warmth to the interior space, as well as a cooking fire. However, an open fire comes with health risks, which are compounded by prolonged exposure, crowded living conditions, damp, condensation, mold, smoke, and particulate pollution in the home, as well as nutritional insult and the effects of cold stress on human physiology can all negatively affect respiratory and immune function. In Iceland, turf structures, such as the skáli, seen here, would have turf walls, in some cases as much as 1.5 meters thick, and presumably with little ventilation. Experimental archaeology from work done in reconstructed structures measured firewood consumption, exposure to particulate matter, and volatile organic compounds, and found that participants were exposed to harmful levels of CO2, benzene, nitrous oxide, among others. Smoke in these experiments tended to draft above wall height towards the roof, but most particulate matter remained closer to its point of origin. In some of these experiments, a thatched roof, such as in the Danish reconstructed houses, appeared to allow air to penetrate, and probably more than a turf house would allow, where the walls and roof are usually made of turf. But this comparison isn't clear. It hasn't been tested as far as I'm aware. So the illustration here shows heat distribution measured. It generally, temperatures in the loft averaged 15 degrees Celsius, but at ground level as low as 5 degrees Celsius, even very near to the fire. An experiment at Eiríksstaðir in Iceland in 2015 recorded average warmer temperatures throughout the house from 8 to 16 degrees Celsius. But this might mean that more particulate pollution remained inside, and again, was the structure possibly less well ventilated? So, to understand respiratory infection in the human skeleton, we have a bit of an anatomy lesson. Why study the sinuses and ears together? Well, sinusitis is inflammation or swelling of the mucous membranes that line the paranasal sinuses, and symptoms may include thick nasal mucus. In paleopathology, most research has been done on the maxillary sinuses because of their size and accessibility. Otitis media, middle ear infection, is the most common sequela of sinusitis. For example, viral upper respiratory tract infection leads to the development of acute otitis media in 37% of cases in children. The middle ear cavity is connected to the nasopharynx by the Eustachian tube, that's indicated by the blue arrow, which helps to pressurize the middle ear compartment. The pain you might experience swallowing when you have an ear infection or a cold is normally actually from fluid that's filling the Eustachian tube, and that's tracking back to the middle ear. The tympanic membrane, the eardrum, separates the outer ear from the middle ear, and the middle ear comprises the middle ear cavity, the tympanic cavity, and the ossicles, the malleus, the incus, and the stapes, which are attached to the tympanic membrane. The oval window connects the middle ear with the inner ear, and middle ear infections are, of course, a very common cause of hearing loss. So the illustration here is an endoscopic view with the tympanic membrane removed, and this is what a healthy middle ear should look like with the ossicles in situ. This is sort of the view I was anticipating when I used the endoscopes to record changes in the skeletons that I looked at. Hearing loss is often recognized as a hidden or invisible disability. Following WHO definitions, hearing impairment or hearing loss can refer to any level of severity. However, deafness refers strictly to profound or complete hearing loss. In this study, I did shy away from using the term deaf for reasons which I will go into a little bit later on. Hearing loss may be conductive, that is, somehow the conduction of the ossicles is disrupted. Sensory neural, in which the inner ear and the nerves would be affected, or mixed, meaning a combination of the two. Nearly all children who have discharge from the ears have some degree of hearing loss. Of course, this may be temporary. Children face particular vulnerabilities with even short periods of hearing loss. Most episodes occur from about birth up to 2 years of age, and generally episodes of middle ear infection decrease by about 7 years of age when the mastoid air cells are developed and help to pressurize the middle ear. One of the real effects that can be measured and observed, especially perhaps by family members and caregivers, are the detrimental effects on speech and language acquisition and even cognitive skills in children, especially if acquired prelingually. That may include consonant loss and voicing confusion. I do have some examples of confusion up here on the slide, but I'd be curious as well what sort of consonants are lost in Icelandic-speaking children. Socially, children may experience isolation and stigmatization. In children, almost 60% of hearing loss is due to causes such as ear infections and birth complications, which are preventable today. So now turning to the osteological evidence, I studied remains from 4 sites, Hofstaðir, Keldudalur, Skeljastaðir, and they are all household cemeteries dating around the year 1000 to the mid-13th century. Skriðuklaustur was a monastic hospital dating from the late 15th to the mid-16th century. And these sites were largely chosen based on their availability at the time that I was conducting my research, for the fact that they are generally very well preserved and contain a decent number of individuals. So despite any chronological discrepancy, obviously Skriðuklaustur is later than the others, for the purpose of looking at the prevalence of disease, looking at it from a biological point of view, it still serves the purpose. Household, by the way, as I'm using it here, should not be taken to be totally synonymous with family, but rather a group of codependent people, which may contain a family or families. We shouldn't assume that everyone is biologically related. So a quick overview of some of the major results to come out of this research shows us that there is a significant association, as hypothesized, between sinusitis and otitis media. And I've got some slides coming up to give you an idea of what I saw. Here is an example of what might be a mild case of sinusitis, where it looks like the mucosa was inflamed and partly ossified. But here we have examples of what were given the highest grade of severity of disease in 2 different ears, 2 different individuals. And here it seems that there's been some exudate from the ear and it's ossified. It was quite hard. I couldn't get an endoscope in there to see anything. In this case, again, they both received the same grade, but the process here has been complete destruction. But I thought that they should receive the same grade of severity because in both cases we're talking about severe hearing loss, most likely. And here's an example in an infant. You can see, in this case, all of the ossicles were preserved. The stapes just fell out as I was taking this picture. And what I found remarkable, what was most commonly recorded in the infants and other ages, was what looks like might be ossification of mucosa across the promontory here of the middle ear. The oval window doesn't appear to be affected. The ossicles didn't seem to be badly affected. So about 50% of the sample, as I recall, received a grade of 2, which indicated that there was something there, but it doesn't seem to have been severe enough to cause long-term hearing loss. So tuberculosis was the most frequently identified specific infection. I've written TB here on the slide as shorthand for lesions that, in differential diagnosis, could be strongly associated with the presence of TB as well as diagnostic of TB. So in this case, we have an example of kyphosis of the spine, which is absolutely diagnostic for tuberculosis. And I have here the remains of 2 different young children. And in this case, these lesions weren't exactly perfectly diagnostic for tuberculosis, but they were classified as being highly consistent with tuberculosis. And there were lesions throughout the skeleton. And what I'd also like to note about these images is that it can be so important to, again, look at the infants, look at the very young, and don't assume that they are too young to exhibit any changes. You'd be surprised at what you might find. So tuberculosis has a strong clinical record of affecting sinusitis and otitis media. We can say with some confidence that most of the cases of sinusitis and otitis media that we see are in fact caused by TB and not by other concomitant infection, because there are numbers of case studies where patients present with ear infection, which doesn't resolve with antibiotic treatment. And in fact, patients are described as returning with worsening symptoms. And so the infection doesn't resolve until anti-tuberculous treatment begins. We can see here that adults and children alike were seriously impacted by tuberculosis. And when we consider that those with the most serious evidence for destruction of the temporal and the middle ear, the potential for cases of profound hearing loss may run as high as 19%. I need to point out quickly that the numbers of non-adult skeletons actually didn't include anyone aged under 4 years in this case. The reason being that they didn't present any sinusitis. And I suspect that actually means our methods of detection are insufficient in such young and individuals who would have been rapidly growing. And I'll speak again about that a bit later on. So the lived experience. The presence of TB in these remains, in the remains of non-adults, indicates continual transmission in these communities. Children are usually infected by adults. By examining the osteological data and describing the lived experience of disease, I propose that it's reasonable to describe TB in Iceland as meeting the criteria for endemic or even hyperendemic conditions. Though urbanization and industrial pollution are often associated with increased rates of respiratory infection, these are not confounding factors here. And this makes Iceland an especially useful context as a largely rural population for honing questions about the risks of indoor environments and the risks and burdens of continuous transmission. This was especially burdening for the youngest and most vulnerable members of the household. So consider, as I mentioned earlier, regarding the experiments, that most particulate matter remained close to its point of origin. Perhaps children were more likely to bear the brunt of exposure to volatile organic compounds and particulate matter simply because of their proximity in height to the open hearth. Furthermore, contact exposure with an adult with pulmonary TB was reported to increase mortality by 70% in children under 5 years of age in high burden settings, and by 8-fold when the mother had TB. Known child-specific risk factors, as we see here, include maternal TB status and sleep proximity, index of infectivity, duration of exposure, and exposure to multiple cases. All of these factors demonstrably increase the odds of contracting TB in children aged 3 months to 6 years in a study from Cape Town. The population might certainly meet the criteria for hyperendemic tuberculous disease, as household cohorts would have spent prolonged time on a regular basis with a group of people, approximately fixed in number, in an enclosed space with, likely, inadequate ventilation. Of course, we cannot measure index cases, but certainly the other mechanisms of disease spread described here could be reasonably inferred to apply to this context, especially the TB status of potential carers or parents, sleep proximity, and a degree of duration of exposure, and the strong likelihood of multiple exposures. This disease burden is therefore a reflection of intimacy in the household, albeit an unfortunate one, and the home environment exacerbated the risks of transmission. So again, reiterating that deaf and non-speaking people did indeed have the means to communicate, articulate their needs and desires in interpersonal relationships and in public life. We should consider that hearing loss was more prevalent in Iceland than we've understood it previously. This research further underlines the importance of not only including non-adult skeletons in studies, but also taking care to understand how disease is acquired and may affect children differently. So, as I mentioned before, at least from about 4 years of age, it seems that some observations about sinusitis are possible. The apparent lack of sinusitis in the youngest may reflect low levels of infection, but I find this unlikely, and suggests that other microscopic methods are required. If this youngest cohort from birth to about 4 years of age are removed from the sample because of the lack of detectable sinus lesions, the prevalence rate among children actually then becomes 54.5%, which is much closer to the rate seen in the adults, and suggests that children and adults were equally affected by sinusitis. So absence of disease in these cohorts might rather reflect problems with our methods of detection. When including the remains of infants and children in studies of otitis media, it's also important to bear in mind that the etiology of disease may differ from adults. Gastroesophageal refluxate has been identified in sinusitis and in the ear effusions of adults and children with otitis media. So it's possible that just babies with their immature systems are actually regurgitating a little bit and aspirating into the ears. Some middle ear adhesions in neonates and infants were identified as epithelial debris and keratin squames contained in amniotic fluid. And that's described in Schukenek's pathology of the ear as lessening after about 4 or 5 months in infancy. And I would advise caution in diagnosing hearing loss, namely because we can't determine with certainty if individuals in the past were actually profoundly deaf. We can propose that profound conductive hearing loss was likely in some cases, especially where it's clear that the ossicular chain was disrupted. But I'm not yet confident that we can identify sensorineural or mixed hearing loss, although in some cases I think it's probably quite likely. Again, we could take this research further to try to unpack other syndemic diseases, and not just other infectious diseases or nutritional insult, but there are reports of depression among people who have to care for others in their community with tuberculosis. So there are lots of angles to take with this. And finally, the skeletal evidence has demonstrated that transmission was ongoing in these households and communities, and was especially burdening to the children in households which were probably hyperendemic for tuberculosis. The household and the home, unfortunately, exacerbated disease. So, thank you, and if there are any questions.
Takk fyrir, Cecilia. Við erum með svona hljóðnám, og þetta í streymi. Þannig að ef þið hafið spurningar þá þetta vönd og ég kem áhafandi fyrir ykkur. Ef ég fattar hvað þetta virkar. Mungar með það?
Já, gott. Ég ætla kannski þá bara að spyrja utan spurningar, eða kannski svona vangavelta. Varðandi loftgæðin inn í skálunum, inn í húsunum. Hefur eitthvað velt fyrir þér, það eru vísbendingar það á nokkrum stöðum hér að það hefur verið leidda loftrásir í gegnum veggina og út að eldstæðunum og svo út, af því að þú varst með myndir frá Læri, hvað hefur að segja það? Hefur athugað eitthvað slíkt?
I think the only other experiment that I'm familiar with, and maybe there's been something more recently that I could check up on, the only recent experiment that I know of is from Eiríksstaðir in 2015. I didn't have a picture of that one, but yeah, and you do, I suppose, have to be careful with these sort of one-to-one comparisons, just comparing the one data point with one data point here, but I thought it was interesting that temperatures were warmer in that house, and was the problem worse in Iceland? I don't know, perhaps.
Einhverjar spurningar úr sal? Já, það spurning. Getum við komið hljóðnemann til þín?
How certain are you that it is not bacteriological destruction other than tuberculosis in otitis media and sinusitis?
Yeah, I went into a lot of detail with this in the discussion of my thesis. Because that's a very important question. And every case study I found of tuberculous otitis media said that tuberculous otitis media is generally more destructive of the mastoid, more destructive of the inner ear than other bacterial infections. And people who were being treated who went to see their care provider because of an ear infection and it didn't resolve, were in a much worse state 6 months, 10 months on, and the only thing that resolved that was treatment for tuberculosis.
In the very young cases, 1-year-old, you don't see Pott's disease there?
No. There is, I did publish a paper a couple of years ago where I went over some of the, a lot of the tuberculosis cases that I've found. I mean, Pott's disease is something that kind of has to happen with age. You do have to live long enough with the disease to develop that level of severity. I did find in a teenager from Hofstadter evidence that there was erosion starting in the intervertebral discs and on the vertebrae, and other markers, infection in the ribs and sinusitis and ear infection, and together as sort of a constellation of signs that can indicate tuberculosis.
Takk fyrir þessa spurningu. Fleiri spurningar?
But yes, actually, the dream would be to get some DNA evidence and know for sure that tuberculosis is what's happening in these skeletons.
Já, Albína.
Hi. I'm going to do it in English. I think it's easier for me, no? Thank you. That was really interesting. Maybe I missed it, but I was just thinking because the buildings at Skriðuklaustur, really are quite different from the buildings at Keldalur and Hofstadter, which are like these more typical Viking age. You didn't see any changes because of those differences or anything like that? Obviously we know also that then the skeletal collection at Skriðuklaustur is maybe not a typical, or probably not a typical one, and more pathological maybe or something. Did you see that in your work, or?
Yeah, I actually haven't, because of time and because of what was available, I didn't actually look at all of Skriðuklaustur myself, though I looked at about a third of it at least, or slightly more than a third. They weren't actually all excavated even by the time I finished the data analysis, but yeah, that's a really important point. It's a different building, but I think people are obviously, most of the conditions that we see at Skriðuklaustur are chronic, and people are coming from their homes, maybe to be treated there. We don't know how long they spent there. But yeah, that's an important point. It's not exactly comparable to, a stone building maybe isn't exactly comparable to turf houses and such.
Jæja, hlumar einhver á annar spurningu, annars ég alveg vissum það að sé að bæði þetta hringja í Ceciliu og senda tölvupóst, og núna getum við fundið það út hvað hann á heima líka. Þannig að ekki brenna uppi með spurningar, sko. Það er ekki gott. Það er spurning í sal.
I've been following these Þjóðveldisöld and to the times now in the late 10-15 years, and one thing we have been one thing that me and my fellows have been looking at is keldur. Keldur was on a farm in High. It was clean water came up there, and it seems to be not so damp inside. Ekki eins mikill raki innan og svo. og timbrið frá 12-13. öld, þannig það virðist hafa enst, verið þurr. Og svona aðeins kíkt á barnadauðan, hann virðist hafa verið lægri þarna í ýmsum fjölskyldum, þarna sóttu ríkustu menn landsins, Jón Lofsson Jóna. Það var vitað að þetta var heilsusamlega manneskju sem menn gerðu svo greina að búa þarna. Nú sem dæmi þá Snorra Húsafelli dó 1803 og hann var 93 ára, svona hár aldur tengist líka því góð heilsufæri. Þannig að spurning hvort að þetta hafi verið staðir sem að fólk náði hærri aldrei og lægri barnadauði, hvort það hafi verið skoðað.
That's very interesting. I didn't know that about Keldur. Yeah, it would be interesting both, I think, to get some experimental archaeology going on in different styles of building, so we understand more about what might be a healthier construction and how did people live.
And fresh water.
Yes, and fresh water. I've sometimes wondered, what were practices of hygiene that people had? You know, how would we try to unpack? Did the household at Skeljastaðir do something in a particular way that wasn't very hygienic, that wasn't being done elsewhere, that again exacerbated those disease conditions? But yeah, that's an interesting point. It could be interesting to look again at the landscape and look at how people are utilizing fresh water and compare that to births and death and rates of infection.
Já, einhverja fleiri spurningar á sal? Mér sýnist ekki. Ég þakka þér kærlega fyrir, Cecilia, fyrir áhugaverðan fyrirlestur. Takk kærlega fyrir að mæta hérna í dag, kæru gestir. Og svo minni ég á næsta hádegisfyrirlesturinn sem eftir hálfan mánuð og verður auglýstur á heimasíðu safnsins. Það fylgist spennt með. Það verður örugglega einhvern geimsteinn þar að ferðinni. Takk kærlega fyrir, takk í dag.
Takk fyrir mig.